One. Please start, sir.
Yeah. Hi, very good evening and a warm welcome to all the doctors who is attending today's evening scientific session. And I would like to thank Dr. Praveen sir and Dr. Neha ma'am for taking your time and giving your presentation in this meeting. With this, today we have two eminent speakers and two talks. One will be with first talk will be with Dr. Neha ma'am. Dr. Neha ma'am, just I would like if I have to introduce, madam has completed. Uh, Sorry, one sec. Madam has completed her MBBS from Shantiram Medical College and Fellowship Surgical Retina from Narayan Nethralaya, Bangalore. Madam is currently head and consultant with Vitrio Retinal Services at Sushila Nethralaya. Their branches are having at Kurnool, Hyderabad, as well as Nellore. And Neha Madam has four book chapters and 10 publications in PubMed journals and 50 presentations in national and international conferences. And Madam also won Best AOS 2017 Retina Poster awarded. With this, I would like to welcome Dr. Neha ma'am to share your screen and start the first presentation, ma'am.
Thank you, team, for giving me this opportunity. Is my screen visible?
Yes, ma'am. It's loading, ma'am.
Can you just check now?
Yes, ma'am. First slide is visible. Please make it as a full screen.
Yeah, I've made it as a full screen. Can you please check now?
Yes, ma'am. Please go ahead, ma'am.
Clear, right?
Yes, ma'am. Please go ahead.
Yeah. Good evening, everyone. Today we'll have a brief discussion on evaluating the need for change in evidence and insights on anti-VEGF therapies. We all know that the current management what we have in wet ARMD are bevacizumab, ranibizumab, aflibercept. We also have new drugs like brolucizumab and faricimab. We all know that there's no cure to this ARMD, but we can obviously help patients from decreasing the morbidity and also maintaining their visual acuity over longer periods. But in real world settings, we know there are significant gaps, like there's economically patient can't afford many injections, and also we also look at the duration of injection. So we have few barriers and challenges to achieve these goals. The challenges which we have to start with, that they are we have significant inter-individual differences because they present to us at different point of time in their disease. Like a few of them present to us early so that we can treat them on time, and they have a very good response to anti-VEGF, unlike some patients who cannot identify it and they present to us very late, and then they don't show, they because of the chronicity of the disease they don't respond so well to the anti-VEGF treatment. And we also have in our armamentarium we have lot of multi anti-VEGF agents with different molecular configurations which act at different levels. The response also depends on different factors, mainly the lesion characteristics and lesion duration, the baseline visual acuity, and patient's age, and to certain extent the particular genotype alleles which with what they present. So there is currently no consensus on how to classify the optimal response. So there is no defined response definition for a good response or a bad response or lack of it. But we also currently, this is how all the studies define the response. The primary response is what we see at 1 month following the last loading dose, that is after 3 injections, and the secondary response is after the fourth visit. is what we see. We also have a ceiling effect that can negate the currently used functional metrics, where we see more than 5-letter improvement is considered as good. It is important to use the parameter along with the response to anti-VEGF on OCT. Now we have both anatomical and functional assessment. We functionally assess the patient using visual acuity, but we also assess the patient anatomically by OCT. So OCT is like a boon to retina specialists now. ICG is usually reserved for patients where we suspect polypoidal choroidal vasculopathy, or we see pachychoroid spectrum or RAP lesion, or sometimes we don't see any response to anti-VEGF therapy. You want to see why the patient is not responding. We do ICG and FFA. So how do we categorize the response, whether it is good, it is partial, or it is poor, or it is non-responsive? We do both anatomically and functionally. The anatomical response, obviously we look at 2-3 parameters. Those are subretinal fluid, intraretinal fluid, and intraretinal cysts. And most of the studies actually look only at the central retinal thickness. If it is more than 75%, they consider it is good response. If it is between 25 to 75%, we say it is partial. If it is 0 to 25%, we consider it poor. And if they are not responding, there is no reduction, or there is increase in central retinal thickness, or the presence of SRF and IRF persists, or there is increase in the height of PED, then we say the patient is non-responsive. Functionally, we look at the logMAR letters. If we see visual improvement more than 5 letters, we say good response. 1 to 5 letters, it is partial. 0 to 4 or 0 to 4 letters, then it is poor response. No response, and there's decline in number of in visual acuity, then we consider it as non-response. So now we have many new anti-VEGF agents which have come up. Is it hope or hype? So if you look at the real world studies with the faricimab, that is Vabysmo, which has newly come. If you see at the studies, they have shown pretty good response in treatment naive cases. If you see the treatment naive cases, the response is significant, the p-value is significant, and you see good response in both the studies. But the problem or the confounding factor we have in the studies is the number of people they have taken. If you see, the n value is pretty low. So the population, the cohort in which the study is done is very low, and it is a short-term study and also a retrospective study. So these are some of the confounding factors. So we really don't know if this p-value is significant or not. And the response after switching from aflibercept, it is not that clinically significant. If you come to the other studies done at Moorfield or for retina, you would see after switching there is not much significance with faricimab, but there's little significance in treatment naive cases. But if you compare this with aflibercept, even with aflibercept, we have comparable results in treatment naive cases. And there's also a study where they had done on 130 eyes, where patients basically are switched after giving aflibercept. They are switched to faricimab, and they have seen if those patients really did well. If we say how did they do well, there are only two things we look at. One is visual gain. The second is how much of fluid is dry. Basically on OCT, how much the fluids is dry and how dry is the OCT picture. And the other important thing we look at now is how much of interval we can give the patient so that he would have injection-free period. So if you look at these three things, that is the reason why we are finding out new drugs. So these patients, once they shifted from aflibercept to faricimab, you can see that from baseline more than 60% have discontinued using this drug, and the reason for discontinuing, 92% had no good efficacy, and 73% were switched back to aflibercept, probably because of the economical thing. So if you see, there is no change in visual acuity from baseline to final visit. This could be a reason. The reason why there is no change is basically if they are already treated with aflibercept, the chronicity of disease is very high. So when you have a chronic wet ARMD, I think we more so look at visual stabilization or visual maintenance. So we don't look for change in visual acuity. So these cases more so will have same vision. So this is a good sign. Even there's no change in visual acuity, it is still a good sign that we could maintain their vision. But if you see the change, the drying effect of faricimab is portrayed that it dries the retina well as compared to aflibercept or the brolucizumab we have. But if you see the amount of CRT change is around 17.9 microns from baseline, which is not significant. And the major factor why we look at new drugs is to look for injection-free interval for these patients. So if you see more than not majority could extend beyond 8 weeks in this study. Next is another study by Kishi et al. Where 53 eyes were previously treated with aflibercept and then they were treated with faricimab with treat and extend regimen and no loading. So it also had similar effect where there is no change in visual acuity and the central subfield thickness also did not change much, and not more than 70% were able to have a interval of more than 8 weeks. So after 3 loading doses, significantly better visual outcomes were observed with aflibercept as compared to faricimab. This is a study by Hara et al. Where you could see that the improvement is significantly high with aflibercept as compared to the faricimab. But if you look at both the groups, the change or significant change in CRT is similar. This is a 6-month study of faricimab in DME. You can see that after 3rd, 4th injection, the amount of change in visual acuity is not significant. Limited improvement is also noted on the intervals in DME period. If you see, the 47% had less than 8-week interval and they required more injections, and the amount of 8 to 12 weeks is around 46%. So very less group, only around 6 to 7% of people had more disease-free interval. So if you look at comparing aflibercept and faricimab, if you are shifting to faricimab, then we expect to have a bigger interval of disease-free period so that patient is assured and they need less injections. So these are all the studies so far what we have done. These all three or four studies are done where the patient was previously on some other drug and then shifted. So this shows that there is chronicity of disease. So chronicity, when the chronicity of disease is already setting in, the comparability between faricimab and aflibercept is on par. Aflibercept is as well doing as good as faricimab. But if you look at the early studies where you compare faricimab with aflibercept, faricimab gives you good time interval of more than 12 weeks. Personally also I have seen that. So the earlier the disease, I think that is when you will have to choose a better drug. So could targeting additional pathways beyond VEGF be beneficial? All these days we were only targeting at the VEGF because we know it is a major pathway which is causing this disease. So initially we were only targeting at VEGF. If you see at ranibizumab, we could target only at VEGF-A. So now we have additional pathways. If you look at aflibercept with nesvacumab. So nesvacumab is something which it targets the angiopoietin 2, but it will not target the VEGF molecule. So we would not give this alone. So they did a study where Ruby or Onyx study where they combined aflibercept with nesvacumab to see if this would help the patients. This is still in phase 2 trials. It is still not done in this is still not done in humans. So they tried seeing if they could combine aflibercept with nesvacumab, where they could target both VEGF and angiopoietin 2. They didn't see any comparable and they also had a control group where they only gave aflibercept and they saw the results were comparable. So even without targeting angiopoietin 2, they were able to achieve good results with just aflibercept alone. So then we have this faricimab, the drug came, where it targets both VEGF-A and angiopoietin 2 even. So this is the 10-year Leukerin study, where they had compared faricimab with aflibercept 2 mg. You could see that the visual outcomes are not inferior, they were almost comparable, but the drying effect and interval period were pretty longer with faricimab. So AVENUE study where ranibizumab and faricimab achieved similar. So this is one study where they had checked for the levels of angiopoietin 2 to see if faricimab is actually targeting the pathway better than the other anti-VEGF monotherapies. But they looked at the levels of angiopoietin 2. The ranibizumab eye-treated eyes and the faricimab treated eyes almost had similar angiopoietin 2 concentration. So why does this happen? This happens because when we are targeting VEGF, the downregulation of VEGF itself will cause angiopoietin 2 to come down. So we don't have to actually target the angiopoietin 2. If we are downregulating or decreasing the VEGF levels, that itself will downregulate the angiopoietin 2 production too. So that is the reason. So the levels were similar in this study. So the preclinical data suggests VEGF is a key driver of angiopoietin 2 production, and anti-VEGF, when it is blocking the VEGFR, then angiopoietin 2 generation itself gets blocked. So we know the VEGFR pathway remains the master regulator in retinal diseases. So this I think everybody knows, so I just want to skip how this angiogenesis is done. The importance of aflibercept, we know along with VEGF-A, it also targets the placental growth factor. This is an additional benefit which we have because placental growth factor mediated effects are still activated through VEGFR1 signaling. Most of these are most of our anti-VEGF agents target the VEGFR2, but even the VEGFR1 gets downregulated with the help of aflibercept. To summarize, with aflibercept 2 mg, already targeting key ligands of the master regulator are potentially targeted, and there is limited potential for improvement in functional outcomes for these patients. The other way of doing is increasing the molar dose of the anti-VEGF can have more extended VEGF suppression and may have more beneficial. So we will have to look at increasing the dosage of these drugs than finding out to target more other pathways. So we have aflibercept targets the key ligands of VEGF pathway, the master regulator of pathological angiogenesis. The targeting other pathways has not resulted in improved patient outcomes beyond aflibercept. The data from PULSAR and PHOTON, where they had increased the dosage of aflibercept to 8 mg, has potential for greater and longer lasting control of the underlying disease as compared to the 2 mg. So these are few of my cases where I started giving Eylea. I usually in my practice have been a good user of brolucizumab, but it hit me hard. I had a case of inflammation, a severe inflammation where I lost the eye. So that is when I've shifted my patients to Eylea, a more safer drug. So this was my case 1. You can see there's a grayish membrane hypopigmented patch with few drusins which are sitting in the macular region. So this is the patient, around 65 years old male he came to me after taking 6 injections of Eylea. He presented to me in June with this type of OCT where his vision is around 624. So he had SRF, and you could see there is a FEPED here. So then because he had already taken 4 injections of Eylea, I shifted him to brolucizumab. Because he shifted his doctor, he was not happy that the fluid is not coming down. So this is how I gave him brolucizumab, and he is a very sincere patient where I'd been giving injections continuously till September, October. You could see the fluid is little decreasing on and off, but SRF always persisted, and his vision is at 624 till December. Then I thought probably because I'd given enough of Peginex, then I shifted the patient thinking this tachyphylaxis. So I considered giving one ranibizumab. So I gave ranibizumab, but still there's no response, and I thought I will give him injection-free period if his vision is not coming down. So I waited for another 5 to 6 months now, and then I started giving him Eylea again. So this was in May, and this is in June, and this is in July. So the patient is still not lost vision. It is maintained, but the SRF is not coming down. So I went back and took an Octa of that patient. You can see a huge vascular net which is there at the outer retinal layer, which is there at choriocapillaries also. So when I did an FFA, there's a late leakage. I thought it is more so towards the pachychoroid spectrum. So I looked at the FFA of this patient, where if I was missing any CSCR and complicated CNVM, so I went ahead and did an angio, and I could see occult CNVM sitting there, but not any particular leakage pattern like how we see on CSR. So presently the patient has taken his last injection was in this month, where I gave him aflibercept, and I'm waiting for him to see. So this is another case of right eye. If you see, there's a grayish membrane which is sitting at the macula. So this patient presented to me in 2022, where I gave ranibizumab injections. Patient couldn't afford more than ranibizumab, and so this is how she is, around 78 years old female. So till 2024, on and off, she was taking injection, and she was fairly responding. Then she lost for follow-up, and then she suddenly presented to me later in October 2025, where the FEPEDs have increased in size, and she had some sort of activity, and the EZ zone is also disrupted. That is when she was worried, because she was at 612 at this point of time, and here she came down to 636. So that is when she opted for aflibercept, and she's fairly doing good now. And after Jan 2026, I've never injected her, but she's on follow-ups. If you look at the other eye, when she presented to me in December 2023, she never had, except for a few drusenoid PED, she never had the disease or wet ARMD in this eye. But in October 2025, when she presented early to me, I can show you the Octa. If you see the Octa picture of this patient, she has a vascular net which is sitting at the ORCC, and the choriocapillary level has not reached the retina yet. So this is the time when a counselor saying, if this injection is given, you do really well. So she took 3 loading doses, and she had a disease-free period till June. So almost from December, it's like 5 months, and then she had very little SRF coming down, and even if you see, the FEPD height has come down significantly. So I injected her again, and I'm waiting for her to come back. So this is a third case, just to show how good the response would be if you're giving it in the early cases of ARMD. If you see, this patient had 6/6 vision because the EZ is still intact, and you could see little of SRF and the FEPED sitting here. So the patient came to me within 5 days of blurring of vision, where the patient was at 618. Then I gave a loading dose of aflibercept, and patient is 6/6 in May, and the drying effect is still there, and there's no recurrence of disease so far. This is case 4, where you could see a small FEPED here, and we had initially given aflibercept August. The patient did fairly well, but patient lost for follow-up, and then he came back with a huge hemorrhagic PD with a little of SRF and an FEPED here. And with one injection, actually the size of hemorrhagic PED and the SRF went down, and then I lost the patient for follow-up again. So these are few of my early experiences with Eylea, and I'm happy with them. Thank you.
Thank you so much, madam, for your wonderful talk and sharing your experience with aflibercept. Now, if any questions are there, we will take towards at the end of the meeting. Now, I'll invite our today's second speaker, Dr. Praveen sir. To introduce Dr. Praveen sir has completed his PG from AIMS Delhi, followed by fellowship in surgical retina. Dr. Praveen sir previously worked as consultant at Vasan Eye Care, Visakhapatnam, and now he's the co-founder of Akshaya Super Specialty Eye Hospital in Visakhapatnam. With this, I would like to welcome Praveen sir to start your talk, sir.
Thank you, Srinivas. I hope my screen is visible.
Yes, sir. Your screen is visible.
My audio is also fine.
Your audio a bit fluctuating, sir. If possible, please keep the mic a bit closer, sir.
Okay, good evening, everyone. On the inside, I would like to thank Bayer for this opportunity. So today I'll be talking more about aflibercept in the cases of PCV. PCV is called polypoidal choroidal vasculopathy. It is a spectrum of the pachychoroid diseases, which many might have been knowing about it. So the evolving role of aflibercept in PCV. This is a disclaimer. So the APVRS guidelines update 2025. So for the diagnosis of PCV, so clinical diagnosis, how can you make a clinical diagnosis? We can say orangish subretinal nodules with majority of the cases having a bleed. Clinically, then we should suspect a PCV, and then followed by which we will do a spectral domain or a Swept-Source OCT, out of which the major findings are the sharp peaked PED, thumb-shaped polyp-like PED, which you might have heard about it, with the RP ring-like lesion. So to confirm the diagnosis of PCV, we usually do multimodal imaging with the fluorescein angiography or ICG angiography, which is considered to be the gold standard, where you will be having branched vascular networks or a bunch of polyps seen on ICGA. So once the diagnosis of PCV has been confirmed, the initial treatment was said to be either anti-VEGF monotherapy or a combination therapy with anti-VEGF with the PDT. So either of which was suggested as the initial treatment according to APVRS guidelines 2025. So after injection was given, we usually monitor the response every monthly with the help of OCT, as many of the centers don't have ICG angiography. OCT is also quite sufficient in diagnosing and monitoring the progress of the disease. So if we usually start with 3 initial loading doses of the injection, we'll see for the complete regression or stabilization of the subretinal fluid. And accordingly, we'll follow the treat and extend protocol. If the disease is persistent or recurrent, we will titrate the treat and extend protocol regimen. So in some patients where it is reluctant, the disease is refractory, we can go with the combination treatment with anti-VEGF and PDT. Or in some cases, we owing to this latest molecules, we either switch to another anti-VEGF agents also. And as I told you before, there can be a large submacular hemorrhage with large submacular hemorrhage, and in such cases, we usually do a pneumatic displacement with or without vitrectomy along with the TPA. So that will help us actually in treatment of PCV with large submacular bleeds. And in some cases where there is active extrafoveal polypoidal lesion, we can do thermal laser ablation along with the anti-VEGF. These are the latest guidelines according to the Asian Pacific Vitreoretinal Society. So the APVRS guidelines states that monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as a monotherapy, because PDT is not that frequently available source for each and every center. Okay, so there is a consensus score of 9, out of which 66% are strongly agreed that monotherapy with anti-VEGF treatment is effective in almost all cases of PCV and can be used as a monotherapy. So today there are no data exploring whether faricimab or brolucizumab monotherapy are non-inferior to the combination therapy. So as Dr. Neha has summarized about the molecules, just a comparison slide. About the four molecules, aflibercept, brolucizumab, ranibizumab, and faricimab. You can see the smallest molecule is the brolucizumab with the lowest molecular weight, and the half-life of aflibercept is 9 to 11 days compared to the other molecules, which is quite low, 4 to 5 in brolucizumab, ranibizumab, and faricimab, quite the similar 7.2 and 7.5 days. The molar dose is also a little bit less for aflibercept, and the targets, in aflibercept, it is a multi-targeted molecule. So it will target 4 molecules, which we'll be discussing. As already Dr. Neha has mentioned, VEGF molecules along with PIGF is also what aflibercept targets. So pertaining to PCV, there are 2 major trials like VIEW-2 and PLANET. So pivotal aflibercept trials demonstrated that PCV can be treated similarly to the neovascular AMD. So many might be confusing that neovascular AMD and PCV belong to same spectrum, but it is not true. PCV completely belongs to a different spectrum called pachychoroid spectrum. But the treatment protocol is similar to the neovascular AMD. That is why people usually get confused. So that is what VIEW-2 and PLANET study has shown. So the mean change in BCVA at week 96 showed the patients with PCV and patients with neovascular AMD achieved similar vision gains with aflibercept monotherapy. And in PLANET study, PDT concluded that PDT can be reserved as a rescue therapy for suitable patients. Not every patient needs to undergo PDT. So we will discuss in detail about the PLANET trial. So PLANET trial is a multi-center trial. It's a sham-controlled randomized clinical study done across 62 centers, where they have given 3 initial monthly loading doses of aflibercept 2 milligrams. Then randomization was done at week 12. In one group, sham PDT was given, and in another group, active PDT was given. And week 52 was the primary endpoint, actually. They have noticed the change in best corrected visual acuity and the safety outcomes also. And week 96, they have extended the study till week 96, where it's a study endpoint. So if you can see these graphs, the mean change in BCVA from baseline through week 96. In year 1, the number of injections required were 8.1, the average injections. Whereas when it comes to year 2, it is almost the half, it is 4.6. So vision gains were maintained using aflibercept monotherapy with optional treat and extend dosing in year 2. So in some cases, the disease recurred or disease did not go away. So they have went for this optional treat and extend dosing in year 2, which still showed a significantly lesser amount of injections required. So patients with extended intervals in year 2 maintained vision gains with a good reduced treatment burden. That is what we mainly aim for. When we're giving these molecules like aflibercept, what we aim to achieve is the injection-free period. So if you can see here, the intervals between the Q10 and Q12 intervals were compared. The aflibercept monotherapy versus aflibercept with PDT was compared, which showed no significant difference across week 96. You can see the similar BCVA change at baseline and week 96. And the number of injections were also significant. When compared between the monotherapy and rescue PDT, it was not much of significant difference. So this itself, we can conclude that aflibercept monotherapy alone can be sufficient in majority of the cases, except in some refractory cases, we can go for rescue PDT. In another trial, the Altair trial, the vision gains were maintained with aflibercept 2 mg treat and extend protocol in patients with or without PCV. So basically, they have compared, they have made 2 subgroups where one is a PCV diagnosed, one other is a non-PCV diagnosed, and they have checked for the mean number of injections. So vision gains were equally maintained in both the groups at through week 96 for aflibercept monotherapy. So similar proportion of patients with or without PCV were extended to intervals. So you can see this Q12 and Q16 the intervals, the last treatment interval was 12 weeks, and it's again showing no significant difference in the PCV group and non-PCV group as well. Maruko et al. Reported similar outcomes with aflibercept 2 mg treatment extent through 2 years, regardless of neovascular AMD subtype. So the mean change in BCVA from baseline through years, and if you can see the PCVA subgroup and typical neovascular AMD subgroup, the treatment burden has been significantly reduced because of this aflibercept monotherapy. The number of injections was significantly reduced in year 2 compared with the year 1. So they had similar outcomes between the PCV and the typical neovascular AMD subgroups. When we see the real-world patients with PCV can achieve vision gains comparable to those in RCTs. So complete polyp regression has been observed across real-world case series with aflibercept in PCV. So if you can see this aflibercept monotherapy Japanese case series, there is a variability in polyp regression rates are likely due to differences in polyp regression assessment criteria across different studies. But we can see aflibercept monotherapy has worked much better, where the polyp regression was significantly good observed in cases of PCV. So more than 50% of the patients were assigned to faricimab Q20 dosing intervals at weeks 44 or 48. If you can see here, Q16 interval was 67.2, whereas in here, if you can see Q20 weeks at we can see compare this 83.4% in Q12. So more than 50% of patients were assigned to faricimab Q20 weeks is what? So there is a small comparison trial. You can see the Salvin study. What they have done is Salvin is a single arm open label treat and extend style, whereas Planet is a fully randomized and masked trial explicitly designed to compare aflibercept monotherapy versus combination. So faricimab has also done a trial, what we call the Salvin trial. It is a multi-center and it has not compared with anyone. The faricimab injection was given and it was just, the results were just given. Whereas the Planet trial, which was done for aflibercept, they compared the aflibercept monotherapy versus aflibercept combination therapy, like the rescue PDT versus sham PDT was also done. So the trial itself showed much significant impact on treatment of PCV compared to the Salvin trial. So polyp assessment, central ICG reading showed outcomes include absence of polyps and absence of leaking polyps at week 52. So in Salvin trial, only 77% had confirmed diagnosis of PCV by CRC. So these trials, if you can see the comparison between the two trials done between the two different molecules, we can see which trial carries more weightage compared to one. So another trial, aflibercept versus faricimab head-on-head trial was done. PCV patients after 3 loading doses, significantly better visual outcomes were observed with aflibercept. This is a Hara et al. Trial. If you can see the BCVA, you can see in this graph, the BCVA significantly improved in aflibercept group at 3 months only after first treatment. But in faricimab group, there was no significant improvement in the visual acuity. And if you can see this bar diagram also, the numerical greater with aflibercept in proportion of eyes with residual exudative changes and complete resolution of PC polypoidal lesions compared to the faricimab group. If you can see, the faricimab group has significantly less number of polypoidal regressions compared to the aflibercept group. This study was done by Hara et al. In PCV patients. So the conclusion of Hara et al. Trial showed that head-to-head comparison real-world study in treatment-naive AMD patients in Japanese population, both aflibercept and faricimab are effective in reducing exudation retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity after the loading doses. So both are like effective in reduction, but if you want to point out to one molecule, which molecule is better, aflibercept definitely showed a more edge. It was more likely to eliminate exudative changes compared to the faricimab. So to conclude, aflibercept's 2 mg efficacy and safety profile has been established across multiple RCTs and is supported over a decade by real-world monitoring. So since launch, greater than 90 million doses were given, and greater than 1 decade we have been giving these injections, and more than 13 million patient years of exposure has been there. So it's approved in total of 7 indications globally, like BRVO, CRVO, diabetic macular edema, macular CNVM, neovascular AMD, and ROP also. And the adverse effects which were seen, which were significantly lesser compared to other molecules. Like we can see rate of endophthalmitis is 0.6 in 10,000 vials. So it is like ADA data suggests that no association with any immunogenic response, unlike some other molecules like doracizumab, where there are significantly higher inflammatory component. So thank you. So to conclude, PCV and neovascular AMD do look similar clinically, and the treatment is also the same. It is on the similar lines, and many studies have shown that the PCV and neovascular AMD can be treated as the same, but PCV does require more rigorous follow-up compared to the neovascular AMD in my experience, and out of which the molecules aflibercept is much more superior to the faricimab molecule in reduction of the oxidative changes which we have observed. And I think in coming more months, aflibercept is coming with a higher molar dose of injections like 8 milligrams, which will be more, which will, I think, increase the duration of injection-free period for the patients and significantly reduce the treatment burden. And as Dr. Neha has rightly mentioned about the addition of angiopoietin 2 arm, there seems to be no significant difference, because nesvacumab study was also done by Bayer people only, but it showed no significant response. That is why that has been stopped. So this is my experience with aflibercept in PCV patients particularly.
Super, sir. Thank you. Thank you so much for your wonderful presentation as usual, sir. Let me check in chat box for any questions. So as of now, no questions, sir. Madam, any comments, madam? Neha, madam.
So how is your experience of aflibercept in PCV, especially the case which I showed, my first case? I really wanted to put it up because I think it is PCV. I don't have an ICG to prove it.
That is what the main problem is. Yes, ma'am, aflibercept is doing pretty well actually with these cases, and I personally have given in cases of submacular hemorrhage also. I've given, because for TPA injection and all, the patient might afford, might not afford, but at least aflibercept they can afford. I have given only anti-VEGF monotherapy in PCV with submacular hemorrhages, and it has showed a quite good response without the normal described pneumatic displacement. Also, the bleed has significantly reduced with one injection only. So when I consequently followed up, I tried to put up that case, but unfortunately the data was missing somewhere, so I couldn't do that. But I was actually very surprised within 2 to 3 weeks only, the response was phenomenal actually with Eylea, which I've given, and later on following up with subsequent injections also, it showed pretty good response of PCVs. But the main problem with PCV is it keeps on recurring. That is the main problem. Yeah. We have to be on a thorough follow-up. That is the main issue with the PCV disease. Do you give TPA more often, ma'am, like in submacular bleeds and all?
Not subretinal, sir. I just give it intravitreal.
You go to it intravitreal.
The results are pretty good. Yeah. I don't meddle subretinal much.
Yeah. That's a little bit challenging with the 41 gauge needle and all, but that is why we just do it intravitreal.
So, sir, actually, one good news is that we got approval for 8 mg launch in India recently. So, company is under the approval process and import license process. Maybe If everything goes right, we might launch during the time of ERSI, sir. You're planning. If it comes, yeah, again, I'll be in touch with you to give real-time updates about 8 mg. Meanwhile, 2 mg will do, sir. So chat box also there is no questions. If there is no more questions, if it is okay to conclude the meeting, is this
Yes, yes, please.
fine? Thank you, doctors. Thank you, Dr. Neha ma'am, Dr. Praveen sir, for your wonderful talks once again. Thank you so much, and have a great evening ahead. And thank you so much for the participating doctors as well. And have a nice evening ahead. Thank you so
Thank you.
much.
Thank you.
Thank you. Thank you.